In this lecture, we're going to expand on the knowledge you learned from the third and fourth year pulmonary embolism lecture and sort of take it to the next level. That is, when you're on the ICU, how do you decide how to manage this pulmonary embolism and where do they go? That's the key here. So you're going to see some of the similar elements to kind of build you up, to get you ready to manage the pulmonary embolism, very similar to that first video. And then we take it to the next level, where we start talking about prognosis and where you should admit them and what therapies you should start for them. So let's start at the beginning, recognizing that PE is simply an extension of a DVT. So since DVT equals PE, let's talk about the DVT first. You're going to see a normal-looking person who then develops a big, fluffy leg. And if you look at our video for fluid where fluid shouldn't be, since you have an isolated limb that's swollen, that's going to be the key that you might have an obstruction somewhere nearby. Now this is the deep vein thrombosis. They often happen in the femoral or popliteal arteries. They aren't usually in the calf themselves. But since there's an obstruction to outflow, fluid's going to accumulate here. The risk is, since that this vein is connected to the heart and to the lungs without any valves, if this clot gets big and flicks a piece off, it becomes a pulmonary embolism. And you can have a pulmonary embolism of something other than a thrombus. You can have it in, say, a leg fracture where you have a cholesterol embolus. You can have it in pregnancy where you send placental contents. But the disease you're going to see the most of, and the one we're going to talk about today, is the thrombus that breaks off and becomes an embolus. The way you get set up for developing a DVT is the Virchow's triad. Venous stasis, endothelial trauma, hypercoagulability. And this is going to be seen in the patient who is immobilized, bedbound, or following trauma. Endothelial injury is the person who smokes, has an intravenous catheter, in particular a central line placed. In hypercoagulability are going to be states where they're having been given extra testosterone or estrogen for any reason, or someone has a cancer or some other hypercoagulable state. You have to have all three to develop a thrombus. But the thing is, even if you haven't identified all three of these, you still can get a DVT, you just missed the triad. Instead, what you should be looking for in a patient who you think might have a DVT is going to be a swollen leg. What you're looking for is a diameter of 2 centimeters greater one side to the other. So you pull out a little tape measure. If one leg is 2 centimeters greater than the other looks pretty normal, you should be concerned for a deep vein thrombosis. You diagnose it with an ultrasound. And once you have confirmed the DVT, you treat with a heparin to Coumadin bridge. You anticoagulate. I'm being brief here on purpose because DVT is not what you care about. You care about the PE. So now we're going to talk about the pulmonary embolism itself. Why it causes the damage it does and why we're going to do our therapies that we do. The body is set up with a series of alveolar capillary exchanges. The first thing that happens in a pulmonary embolism is essentially an occlusion of flow through this particular vessel. Oxygen and carbon dioxide can be exchanged, but since there's no flow through here, it doesn't matter. What this alveolus senses is essentially hypoxia here. So because this doesn't work, blood is going to be shunted everywhere else. But the major problem of a PE is not the obstruction itself most often. It is instead the platelet-derived mediators, such that there becomes a leaky capillary through inflammation, and there will be pulmonary edema. CO2 is perfusion limited. It does not matter the size of the barrier, CO2 can get out without difficulty. O2, oxygen, is diffusion limited. The bigger the barrier, that is, the more fluid that's here, the less oxygen can get from the alveolus into the capillary. Thus, not surprisingly, the pulmonary embolism usually presents with tachypnea or hypoxia. I'm being brief because it's explained very well in the other pulmonary embolism video in great detail. The point being that the person is going to attempt to get more oxygen into their system by breathing faster and picking up the heart rate. And if you were to get an arterial blood gas, you would see the CO2 gets out without difficulty, but no matter how fast the heart beats or how much they breathe, oxygen can't get in. Low oxygen, low CO2, high pH. A hypocapnic, hypoxemic respiratory alkalosis on an arterial blood gas is indicative of a pulmonary embolism, just as is simple hypoxia. But if you look at our pulmonary hypertension lecture, you know that pulmonary hypertension can actually lead to right ventricular strain. When you have hypoxia at any one point, the response is vasoconstriction. If platelet-derived mediators are sent throughout the lung, that is, this small thrombus sends platelet-derived mediators systemically throughout the lung, you're going to have multiple alveolar capillary exchanges with an increased fluid barrier between them, which means that each one of these exchanges is going to be hypoxemic. And so the response is vasoconstriction. So even though you have a small thrombus and a simple arteriole, you can still produce profound hypoxemia by causing significant pulmonary hypertension. And it is the platelet-derived mediators that become the target of our therapy. And I will tell you the punchline up front. Even if you perform a thrombectomy, even if you break up the clot and get rid of it, if there is right ventricular strain, it may not be improved. By removing the obstruction, you may not remove the increased pressure because you still have platelet-derived mediators causing peripheral vasoconstriction throughout the entire lung because of hypoxemia. Now, it's a big statement, so let's just talk about the Wells criteria and readdress this information as we talk about our treatment. You see someone who's short of breath, you see someone who's tachypnic and tachycardic. You use the dyspnea pyramid in our methods section to try to figure out what's going on. You're going to get an arterial blood gas, an EKG, 12 lead, and a chest x-ray. If you happen to see a clue for pulmonary embolism, you are quite lucky. That is, the ABG may show you the elevated pH, the decreased PCO2, and the decreased O2. It does not mean this is a PE, but it's suggestive of it. An EKG may show you an S1Q3T3, indicative of right heart strain. Often you don't see it. And if the pulmonary embolism is quite large, the chest x-ray will reveal a wedge infarct. Chances are you won't see these things even though there will be a large pulmonary embolism. And because the pulmonary embolism is so difficult to diagnose clinically, there is the scoring system called the Wells criteria that helps us make decisions. The Wells criteria takes into account a number of elements, and it's used in two ways. The first way is to separate it, is the modified Wells criteria, and separates it with a flat number. If the Wells criteria is greater than 4, you get a CT with PE protocol. If it is less than 4, you don't. Simplest way to use the scoring system. The other way to do this is a 3-tiered system. The Wells criteria can help you get an idea for what the pretest probability of a pulmonary embolism is. And here's how it works. If the Wells criteria is less than 2, you get a D dimer. A Wells score of less than 2 is indicative of this is probably not a pulmonary embolism, it's probably nothing. But you have to recognize that if you get a D dimer in the acute inflammatory setting, it will be elevated even though there's not a pulmonary embolism. So the joke I make is when you get a D dimer in clinic, when you don't think there's a PE at all, aka don't order a D dimer, because the only time it's useful is when your pretest probability is so low, you've basically ruled it out already. If the Wells criteria is greater than 6, get a VQ scan. The VQ scan is only useful when you have a very, very low probability of PE or a very, very high probability of PE. That is to say, if the VQ scan matches your pretest probability, you have confirmed your suspicion. If it doesn't, it's not useful. So any combination of low, middle, or high probability, other than low probability, low scan, high probability, high scan, anything else other than those two is useless. The VQ scan also can only be done in someone who has normal chest X-ray without any other abnormalities, and in someone who is awake enough to take a big deep breath to take in the radioactive material. The reason why I've got the dashed line here is because you see that the utility of the VQ scan and the D dimer are not very high in the acute setting. That is to say, you want to do the CT with PE protocol if you're able, and if you have some contraindication to the PE, which is, say, renal failure, so you can't give them intravenous contrast, you can use the D dimer or the VQ scan, but knowing that their utility is significantly reduced from the original Wells paper. You can look up the Wells criteria. I'm not going to list them for you now, but I do want to make light of one of them, which gives you 3 points. That is PE as likely as another diagnosis. What that means to give the person 3 points for that, because 3 points almost pushes you immediately to PE. If you're tachycardic and you give those 3 points, you get the scan. You should not do a CT scan on everyone who is tachycardic. The reason that is there, the points for PE more likely than any other diagnosis, is when you have exhausted your search for other causes of shortness of breath or the tachycardia. You have no idea what's going on, and holy crap, what if it's a PE? The idea is that 3 points is reserved to give you the scan when you ruled out everything else. So don't lump those 3 points in right off the bat, because if you do, pneumonia, it could be pneumonia, could be PE, you're always going to scan them. That's a waste of resources. All right, so the Wells criteria is really what you're going to use. And it's going to help you decide, do you get a CT scan with PE protocol? You need to give IV contrast. Do you get the D dimer? Almost never. Or do you get a VQ scan because you can't do the CT with PE protocol? Once you're here, you're going to diagnose the PE on the CT scan. And now you have a pulmonary embolism, and now you have to decide what to do about it. And this is really where you're going to get the benefit of this lecture over the one for the 3rd and 4th years. Is a spectrum of pulmonary embolism. There is the asymptomatic PE, a symptomatic PE, a submassive PE, and a massive PE. The asymptomatic PE goes home. The submassive and massive PEs go to the intensive care unit. The symptomatic PEs go to the floor. That is that you do not get admitted if you have an asymptomatic PE found for something else. This is the CT scan of the abdomen for abdominal pain that happens to find a pulmonary embolism. You decide what you have, asymptomatic, symptomatic, submassive, or massive, based on 3 things. The first, of course, is symptoms. The second is whether you have anatomy. And by anatomy, I mean evidence of right heart strain. The third thing is vitals. That is, are they hypotensive? The asymptomatic PE will not have symptoms because it's asymptomatic. It's not going to cause right heart strain, and there won't be any change in the vital signs, which is why you can send them home. The symptomatic pulmonary embolism will have symptoms, but will not show any evidence of right heart strain and will not be hypotensive. This person goes to the floor because they are symptomatic and need acute management so they don't turn into submassive or massive. Now watch how this flushes out, and you can see how this chart's going to fill in. Submassive and massive, of course, are going to be one step up from symptomatic, and they're going to both have symptoms. The thing that makes a submassive PE submassive is not the size of the clot on the CT scan. It is the presence of anatomy. That is, there is evidence of right heart strain. There will be right heart strain on massive PE. The difference between these is that the submassive PE does not show signs of hypotension, where the massive PE does. Here's why it matters. All of these are going to be treated with heparin to Coumadin bridge. But the asymptomatic PE can go home. They get subcutaneous low molecular weight heparin to Coumadin bridge. They get educated and sent home. Low molecular weight heparin to Coumadin. The symptomatic PE gets low molecular weight heparin to Coumadin. Why? Because a heparin drip is annoying. You have to draw blood every 4 hours. And the heparin drip is there to stabilize the clot and defeat the platelet-derived mediators. If all you have is a little shortness of breath or a little tachycardia, you don't need that infusion of heparin. You can use low molecular weight heparin and bridge to Coumadin. This is, of course, assuming they don't have renal failure and don't have another indication for a heparin drip. These patients are monitored in the hospital overnight to make sure that they don't turn into a submassive or massive PE. But they can go home the next day. They don't have to stay until bridged if you trust them. They may take a couple of days to become therapeutic. The difference is in the submassive PE, now you have to worry about right heart strain. There is pulmonary hypertension and you have to prevent it from killing them. So they need intensive monitoring in the intensive care unit because the difference between submassive and massive is just the vital signs. So they need to continue monitoring of their vitals. The submassive PE gets a heparin drip to Coumadin. Heparin drip because their risk of bleeding is higher and their risk of turning into submassive PE is higher. You need to turn off those platelet-derived mediators with a constant infusion to break up the clot. The massive PE, the treatment is TPA. You don't wait for the heparin to try to stabilize the clot and the Coumadin and the endogenous system to break apart pulmonary emboli. And that's the thing. Most pulmonary emboli will be defeated by the body themselves. Yet if they come in with symptoms or submassive, you need to support them with the heparin. The massive PE, their vitals are already low. If you don't remove that obstruction, they're going to die. So you give TPA. The big deal of choosing floor versus unit is going to be in right heart strain. How do you assess for right heart strain? You assess for right heart strain with a troponin, a BNP, and a 2D echo. Dilated RV, big right atrium, elevated BNP, elevated troponin in the setting of a PE makes it submassive. So when you're on the floor and you say, hey, I've diagnosed a PE, and you call the unit, to call the unit and say, I need to step this person up, they should have an elevated troponin or an elevated BNP or dilation of the right ventricle or right atrium on 2D echo. If they don't have any of these things, they can stay on the floor and get low molecular weight heparin to Coumadin bridge. If they have any of these positive, they go to the unit for closer monitoring. And if at any time they get hypotensive, TPA. There's one last kind of pulmonary embolism. This is not an acute presentation. That is the chronic thromboembolic pulmonary hypertension. The person has pulmonary hypertension with PEs diagnosed either by angiogram or CT or VQ scan, these people get thrombectomy. Have I seen thrombectomy used for massive PE? Of course. But as you learn and first begin to study pulmonary embolism on the floor and in the unit, I want you to recognize that thrombectomy is reserved for pulmonary hypertension secondary to pulmonary embolism. TPA is the preferred choice for massive PE. If you can't give TPA because of a contraindication, then you use thrombectomy. Submassive PE is treated with a heparin drip, symptomatic PE with low molecular weight heparin to Coumadin bridge that may be completed at home after a short observation. And asymptomatic PEs don't have to be admitted at all. This is the crux of the lecture that I really wanted you to get in this bonus content. A brief discussion of the Wells criteria and management of where the person goes and how you treat them is what's significant. If you want to review the pathogenesis and sort of the laboratories you might see, check out the pulmonary lecture of pulmonary embolism, the 3rd and 4th year clerkship videos. That is pulmonary embolism. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.